Hello, I'm Paul Wakim. I'm a biostatistician at the NIH Clinical Center, and we're going to be talking about statistical considerations in preparing your manuscript. I'm not big on long introductions, so we're going to dive right into it. And this talk is going to be divided into two main parts, some general points about preparing a manuscript, and then some more specific issues and recommendations. Now, some slides are directly related to clinical trials, but in general, most of the points I'm going to be making are applicable to all types of research studies. So let's start with the general key points. And I want to start with this statement: maintaining or increasing the public's trust in scientific research entails performing all of the following steps at high quality levels: developing the primary research question, designing the study and planning the analysis to answer the primary research question, monitoring the study's progress, performing the final analysis, and reporting the results. All of these points are important in order to do research right. I mean, we at NIH, this is an important part of our responsibilities to ensure good research. And poor scientific research has devastating negative effect on the public's trust in science. So it's important that scientific research is only as good as the weakest link of these points. So my first question is, what is the most important part of the research study design? And in a live one-on-one kind of presentation, I would pause and listen for answers. But of course, we can't do this here, so I'm going to give you the answer. And that's the primary research question. It is by far the most important part of a research study design. And I would suggest not only that, but you put it as a question. Put it as a question in the form of a question. You'll be surprised how many investigators jump into the details before they establish the question, the primary research question. Now, I'm not saying it's easy. All I'm saying is that it is extremely important to do that. You know, I've heard people say, oh, but you know, it's a pilot study, it's an exploratory study, it's an observational study. In other words, oh, do we have to be so strict? Yes, it doesn't matter what kind of research, what type of research it is. You still need to have a question in order to conduct the research, and you have to have a plan. So what is the second most important piece of information in a proposed study? And that's the primary outcome measure, the primary endpoint. I mean, you have a primary research question, and the primary endpoint is basically going to help you answer that question. So we need to quantify or operationalize the primary outcome measure in order to answer the primary question. So here are some examples about objective. I'm going to show you the bad, the better, and the best. The bad is going to be something like, and I made it up, to better understand the effect of treatment on cancer. And now that's just not saying anything. You can cut and paste this on any proposal that has to do with cancer. That's not good. Something better is to clarify the relation between supplemental N3 fatty acids and risks of cardiovascular disease and cancer. Okay, so this is a little bit more specific, but still not ideal or not best. So what's the best? The best is what is called, the PICOT question. I'm not sure who came up with the acronym, but I found it in a paper by Stilwell in 2010, which also reminds me that I'm going to show you the references at the end of this, and I'm going to just give you 2-3 seconds on each slide for the references, and you can obviously pause the video to look at the references more closely. So Going back to the PCOT question, what's PCOT? PCOT, P is for population or disease, I is for intervention or variable of interest, C is for the comparison group, O is for outcome, and T is for time. So the primary research question would say something like, in population P, how does intervention I compare to comparison group C or the control group C influence the outcome O during the time T? And a little bit more concrete example, you would say in patients age 65 and older, that's the population, how does the use of an influenza vaccine, that's the intervention, compared to not receiving the vaccine, that's the control, influence their risk of developing pneumonia, that's the outcome, during the flu season, and that's the time. How good is the primary research question? Well, if you want to test the primary research question, if whether it's a good one or not, ask yourself the following. At the end of the day, when the research study is completed and the data analyzed, will the answer to the primary research question advance scientific knowledge and or clinical practice? Basically, are we going to be better off because of this research? It doesn't have to be the cure from the cure perspective. It could be just from scientific knowledge. So, and that's very important. Should one always publish results? So here, I'm going to answer with the following. Now, I'm going to put the exception if it is sloppy research. If it is sloppy research, yes, don't publish. It's better than not to publish. But other than that, it is imperative to publish research study results. And failing to do so is unethical and irresponsible. You may think, boy, this is really strong words, unethical and irresponsible. Well, yes, I do believe that, and it's unethical because you're in clinical trials, you're subjecting people to potential risk, and for nothing. If you're not going to publish the results, all this was for nothing. If it's a government grant, you're basically spending taxpayers' money for nothing, for no benefit whatsoever. From a scientific perspective, you're not letting the scientific community know what you did and what didn't work. So they don't know what you did if you don't publish, and they may repeat the same thing that you did and also find a null result or run into the same problems you ran. And finally, if there's what's called publication bias, you run a study, you don't find positive results, you don't publish. The next person does the study again, doesn't find a positive result and doesn't publish. And after 6, 7 by chance, somebody's going to find a positive result, but that's by chance. It's not real. And then they publish, and then that's obviously very misleading, because then people don't see the ones that didn't make any difference, where the treatment didn't make any difference, but they see the one that by chance showed results. And so the scientific community is going to believe that, oh yeah, that treatment works, when in fact it doesn't. So for these reasons, it is important to publish results, as long as it's good research. And now with the Food and Drug Administration Amendment Act of 2007, clinical trials that fall under this amendment, it is illegal not to report results in clinicaltrials.gov, and there are steep fines for not complying. So things are getting a lot better than they used to, I don't know, 10, 20 years ago, but we still need to be, stick with it. Failed study. I remember the first time I heard this expression. This was a failed study, meaning that we didn't find that the treatment works, the new treatment works. We didn't find that the treatment is better than placebo. It is a failed study. And I remember the first time, I really didn't like that. I really don't like that. To me, if the primary research question is important, the result is important, regardless of whether it is positive, negative, or null. And a well-designed and well-conducted research study that produces a null result is not a failed study. It basically advances scientific knowledge. How it eliminates a hypothesis from a list of interesting yet untested hypotheses, and then shortening that list. In other words, you know, so you have a list of possible treatment that are going to do some good, and then you start with the highest priority, the one you believe is the most likely to produce an effect, and it doesn't. Well, okay, fine, then you move to the next one. So it does advance scientific knowledge. And I want to just mention, the list here is not important, the journals that are dedicated to null results. And a few years ago, I checked this list. They're still around, but the point is not really the journals themselves, but there are journals that are dedicated to publishing null results, meaning results that didn't find a difference between the new treatment and placebo, for example. Or whatever. The hypothesis was that there is an association between A and B, and the study found that there is no association. So these are all null results, but that's okay. They need to be published. They need to go out there. And I borrowed this information from the NIH library about identifying and selecting a journal. And they basically warn people to avoid questionable journals, predatory journals, because when they offer quick publication, open access for a large fee and no peer review, just be aware of those, because they're just in the business of making money. Search for PubMed or Journal Citation Reports databases. And there is this website, again, this is a recommendation from the NIH library about it's called Think, Check, and Submit. And that's the website address. So the primary analysis. Sometimes I'm asked, well, okay, we're going to publish the primary analysis. What is it? First, what is it? The primary manuscript presents the answer to the primary research question. You know, so people, you know, people run a clinical trial or study, may publish several papers on the same study. So they start with the most important result, or the primary research question. And sometimes they ask, well, what should I include in this primary manuscript? And basically the answer is to include the primary analysis, obviously, i.e. the one on the primary outcome measure and primary hypothesis, but also include results from other analyses that are key to properly interpreting the main conclusion. So anything that's around the main conclusion that clarifies or that helps properly interpret the main conclusion, these have to be in the primary manuscript. What are secondary analyses? They're all analysis other than the primary analysis. Okay, that's not very informative, I accept that. But they can either be pre-specified or not pre-specified. Okay, what is pre-specified? They were in the plan, they were in the proposal, that was part of the plan. Or not pre-specified, they're kind of ad hoc, exploratory. After you got the data, you're thinking of a question. And it's important to make that distinction. You know, between pre-specified and not pre-specified. In terms of the weight of the result. I mean, if you tell me this is a question I had in the plan and this is what I found, okay, I would give it a bigger weight than if you told me, well, you know, we collected the data and we ran all kinds of things and we found this. That has less weight. So pre-specification is important. Typically, the study's sample size is based on the primary analysis, and not on the secondary analysis, except if the secondary analysis is key. If there is one secondary analysis that is key, then it should also be reasonably powered. And by reasonably powered, you say, okay, so the main question was powered at 90, 95. Reasonably powered could be, you know, 75, 80, 85, or something like this. And of course, you do the power for the primary question, you do the power for the secondary analysis, and then you take the higher of the two sample sizes. What are examples of secondary analysis? You may be interested in important endpoints other than the primary. I used to work for the National Institute on Drug Abuse, and you know, this was clinical trials. Basically, typically, the primary outcome was abstinence or retention. Sometimes it was complete abstinence. Sometimes was, you know, less than so much per week, per month. So they were all very important in drug abuse. The retention is very important. Going to the treatment is just itself very important. So this is other important endpoints. You can use them as secondary analysis. Or additional assessment that you collected. Site characteristics. In a multi-site trial, you want to collect some site characteristics. In economic analysis, in genetic studies, and in subgroup analysis. And we're going to talk a little bit more on subgroup analysis. But subgroup analysis is part of secondary analysis, but they are a specific type of secondary analysis. So what is a subgroup analysis? What is a subgroup? A subgroup is defined based on baseline characteristics. Baseline means pre-randomization in clinical trials, but it's right at the beginning of the study. So examples, gender, race, age group, serotype, socioeconomic status, geographic location, severity of disease, comorbidity with other disease. These are baseline characteristics, and subgroup are based on these baseline characteristics. So again, but what is a subgroup analysis? Well, a subgroup analysis focuses on differences in treatment effect amongst subgroups of trial participants. So if you're talking about a clinical trial, you're talking about differences in treatment effect. If you're talking about a survey or any kind of research and you say, okay, I found an association between A and B. Well, but this association between A and B applies to men and women? Or is it just to men, and it just there were so many more men than women that the overall was a positive association? So it doesn't matter whether we're talking about a clinical trial and differences between treatment effect, or we're talking about association. Whatever the primary research question is, subgroup analysis asks, well, whatever I found overall, is it really the same for this subgroup, the young folks and the older folks, men and women, whites and blacks? I mean, that's subgroup analysis. And again, they are pre-specified or not pre-specified. So again, the same story. Pre-specified, you say, you know, I'm going to look in the plan you have that I'm going to look into this. Ad hoc means, or not pre-specified means, okay, why don't we look into this after the fact? And typically the study sample size is not based on subgroup analysis. So I'm going to show you now a really nice table where they put a lot of results from subgroup analysis into one concise table. So I'm going to talk to you a little bit about this table. So this is a three-arm study, three treatments. The one treatment was a Mediterranean diet supplemented with extra virgin olive oil. The second was a Mediterranean diet supplemented with mixed nuts. And the third was a controlled diet, the advice to reduce dietary fat. So in this table, what they did is they combined the two Mediterranean diets into one. So this column is really the combined, the two Mediterranean diets combined, and this column is the control diets. We're not going to go, I mean, they talk about hazard ratio. Hazard ratio is like relative risk. We're not going to get into that, but basically just know that the hazard ratio, when it is equal to 1, it means that the two diets are the same. When it is, and they tell you here, when it is to the left, it shows that the Mediterranean diet is better, and when it's to the right, the control diet is better. So for now, that's all we need to know. So what happened with this trial overall? The primary outcome, first, the primary outcome measure is a composite. So when they say the diet is better, what does it mean better? Well, it's about a composite of myocardial infarction, stroke, and death from cardiovascular causes. So that was the primary outcome. And overall, they found that the overall hazard ratio is 0.71. Confidence interval goes from 0.56 to 0.90, and the p-value is 0.005, meaning that overall, they found that the Mediterranean diets were better. Fine, but that's not that's not why I'm showing you the slide here. What I'm showing you the slide is about subgroup analysis. And so as an example, let's take the first one, which is sex. So we have male and female. And so we look at these two confidence interval and we say, oh, it looks like for male, it doesn't cover 1. The confidence interval doesn't cover 1. And therefore, it really, the Mediterranean diets were better for men, but look, for female, no, it does cover 1. So they were the same. The Mediterranean diets and the control were the same. So for male diet, the Mediterranean diets worked. For female, it didn't. My point is, that's not the way to do it. Okay, so I want to be clear. That's not the way to do it. You don't look at each one and compare it to one. The real question is, are these two confidence intervals different? Or another way of saying, are they different from the overall hazard ratio? That's the question you should ask. Not that one covers and one does not. That's not the way to do it. Okay, so how do we do this? We look at the p-value for interaction. The interaction is the treatment by sex interaction. Or the next one is the treatment by age interaction. That's how you look for it. And here, the interaction is 0.62. And so there is no interaction. So it was not different between males and females. The treatment effect was not different between males and females. And that's the way to do it. So if I look at another one, I was looking at BMI, for example, and the p-value for interaction. So we're talking about treatment by BMI or BMI by treatment interaction, doesn't matter. Either direction, it's the same. The p-value for that interaction is 0.05. Oh, okay, is there something? Well, let's look at the confidence intervals. What do I see here? Well, it looks like that the greater than the 30 BMI, so I would say in English, for people with a BMI greater than 30, the Mediterranean diets seem to be working, but for the others, probably not. And that's not because one covers and one does not, because I started with the p-value for the interaction, then I look at the graph to understand what's going on, and this is my best interpretation. And that's the way to do it. Another way, which was suggested by Kuzik in 2005, and the reference is at the end, is to, instead of putting a vertical line at 1, you put the vertical line at the overall hazard ratio. So you put it as 0.71. And now you ask yourself, now if we go back to the male and female, are they different from the overall? No, they're not. Males are, for males, the confidence interval covers the overall, same for females. So that's another way of looking at it. And that's, to me, is a better way to look at it. It reflects more that p-value for the interaction. And if you look at BMI, you can see that, you know, the BMI greater than 30 is really to the left of the overall. Okay, so that was for, so in general, subgroup analyses are very important. They are valuable for generating new hypotheses. They should be based on clinically plausible hypotheses. In other words, you should say, okay, I have this question. I was wondering about this. And then you answer it rather than just, you know, let's try everything possible and let's see what we get. They should be pre-specified. And then you say, well, they should be limited to a handful. Well, okay, they should be pre-specified. I'm going to pre-specify 200 secondary analysis. Well, no, that doesn't solve the issue. They should not be interpreted as definitive results because they were not powered to do that. And their limitations should be clearly reported in manuscripts. Okay, so that's the general key points I wanted to make. And now we're going to move to kind of more specific statistical issues along with some recommendations. Okay. So, number one, publications before study completion. Should I publish before the study is over? Well, for complex designs and research plans, consider publishing the plan without the results before the study is completed. And there are several reasons for this. I mean, at the beginning, when you design the research, all the debates and the pros and the cons are still fresh in your mind. And so it's a good time to write them down and publish them. And also when the trial is completed or the study is completed, well, you're so busy with, you know, cleaning the data and writing the results that you don't have much time on just writing the design of the study or the plan of the study. So it's a good time to do it before the study is completed. And the third advantage is when you write the results, you can refer back to the manuscript that talks about the plan that goes into details about the study design or the research plan. For clinical trials, you may also publish baseline characteristics. This is pre-randomization characteristics, not by treatment condition, before data lock, but after recruitment is completed. First, let me explain data lock. Data lock is an expression that means basically that when the trial is completed, everything has been collected, people go over the data without any analysis, go over the data to make sure the numbers are right, missing values are filled if possible, etc., etc. Anything that doesn't look right. And then once that is done, and before any analysis, you lock the data, meaning you're not going to touch it. You're not going to change it anymore. That's it. You lock the data. So you can publish baseline characteristics before data lock, but after recruitment is completed. Now, why these restrictions? Because to avoid any bias, you know, any perceived bias. You want to start publish results and then they don't look like you want, and then consciously or subconsciously you start biasing the rest of the study. So it's a very subtle, but you know, just to be safe, just when the recruitment is completed, then you can start publish only baseline characteristics. And then there's these formal called interim analyses, the publication of interim results. For randomized clinical trials, do not present, report, or publish any preliminary post-randomization results before data lock. And people do that. It's amazing. People do that, and it's not advised. Again, it's because there's this potential of bias. You publish an interim result, people get excited, and then the rest of the trial doesn't go quite the same way. But you've invested so much and got so many people excited. It's very easy to fall into some bias. And again, bias can be very subtle. Unless there's an exception, unless you're going to do Bayesian analysis. So if you're going to do Bayesian analysis, in a way, Bayesian analysis, I'm not going to get into what Bayesian analysis is, but you have a prior and you have data, and then you get a posterior, and that posterior becomes the prior for the rest of the trial. So with the interim analysis, you have the prior, the interim data, and the posterior, and that posterior is going to become the prior, but that prior is locked. So you can't change it anymore. And so you can continue the trial. Okay, primary research question and primary endpoint. How do you write about those? In both the abstract summary and body of the paper, be clear on what is the primary research question and the primary endpoints. What are the secondary and subgroup analysis? Were they pre-specified? What are the results of each separately? And I'm going to give you an example. So this is a trial, a randomized clinical trial of cognitive behavioral therapy and interpersonal psychotherapy for panic disorder with agoraphobia, which is fear of crowds. From the abstract, it says, this study aimed to directly compare the effects of CBT, cognitive behavioral therapy, versus IPT, interpersonal psychotherapy, for the treatment of panic disorder with agoraphobia. That's the objective. Primary outcomes were panic attack frequency and an idiosyncratic behavioral test. Secondary outcomes were panic and agoraphobia severity, panic-related cognitions, interpersonal functioning, and general psychopathology. What I like about this, it is very well written. It's aim, primary, secondary. And then when you go to the results, again, from the abstract, they say, intention to treat analysis on the primary outcomes indicated superior effects for CBT in treating panic disorder with agoraphobia. Sensitivity analysis. Per protocol analysis, this is another way of doing the analysis, emphasized the differences between treatments and yielded larger effect size. So the primary analysis, sensitivity analysis on the primary research question, and then the results of the secondary analysis. Reduction in the secondary outcomes were equal for both treatments, et cetera, et cetera. So primary research question, primary analysis, primary research question, sensitivity analysis, and I'm going to talk about sensitivity analysis, and secondary analysis. So statistical method and analysis, how do you write that? Avoid general language, such as for categorical variables, we use the chi-square test, and for continuous variable, we use the t-test. I mean, again, I can, copy and paste this in all kinds of papers, and they don't say any specific to the paper I'm reading. Be more specific. For example, for pain level, which is a categorical, we use the chi-square test to compare females and males. For blood pressure, which is continuous, we use the t-test for the comparison. Okay, so now I know what you're talking about. I know we use the test to do what? You're basically saying here. For statistical models, clearly list and indicate the dependent and independent variables. Okay, here are some of the expressions that are interchangeable. People, in some cases, they write DV for dependent variable, or response variable, or outcome, or the Y variable. They all mean the same thing. Independent variable, explanatory variable, predictor, X variable. They all mean the same thing. Whichever expression you prefer is fine. The one I like and the one that is mostly used by statisticians are these two. Response variable for the dependent variable, that's the response. And the explanatory variable, these are the X variables because they explain the variability of the response variable. A little bit more on terminology. Univariate, bivariate, and multivariate. These are all analysis about the dimension of the response variable, meaning is the response just one number, or is it a vector of two numbers, or is it a vector of multiple numbers? So how many assessments are there per subject? I'm not talking about longitudinal and repeated measure. I'm talking about at a given point, I'm measuring three things, or maybe the answer to question 1, the answer to question 2, and the answer to question 3, and I want to analyze all three as a vector. It is rarely done in biomedical research. You know, the vast majority of the models are univariate analysis, meaning one response. One response per observation, versus univariable and multivariable analysis, which is univariable is one explanatory variable, and multivariable meaning more than one explanatory variable. So I think it's a good idea to just follow this convention, and so that we're all on the same page. That's all. And I was just saying about standard deviation and standard error. Just be clear that standard deviation measures the spread of the data. It's used as a descriptive statistic. It just says the data is spread this much. That's it. Standard error is about an uncertainty around an estimate. Is used in statistical inference. You're trying to estimate something, and you're getting the standard error of that estimate in order to get, for example, a confidence interval. And that's a very different, that's not the spread of the data. That's the standard deviation. Sample size. In the text, in the manuscript, be clear in the text about the total sample size. Just how many observations, how many people do you have in your sample? Have to be very clear about it. Some people have a chart. They say we started with so many, and then because of this, we went down to so many, and that's beautiful. And then because of this, we went down to this much, we went down to this much, and this is what we analyze. This is the N we analyze. That's really perfect, because then the reader knows exactly what happened. So in each table, because you may have different missing values, different observations, different whatever. If the sample size changes from table to table, then put the sample size in each table. And if sometimes within the same table, the sample size changes because of missing value, if you say the percent who said yes and the percent who said no, but then how many missing, either you add a column to say how many are missing, and then you can keep the overall N, or you say only the yes and the no, but then you have to tell what's the total N for each one. Now, if you have the count and the percent, obviously you don't need to put that. With repeated measures, so this is, over time, you got several assessments, report how many participants, how many observations, and the range of repeated observation per participant. So you would say something like 1,257 assessments, that's my data. My data has 1,257 rows, but they are from 826 participants. They're from 826 people, because I've got something between 1 and 5 assessments per person. Okay, so this gives me a sense of, the whole, pretty much a good sense of the picture. 1,257 observations, 826 different participants, and each participant can have anything between 1 and 5 assessments. A definite no-no for sample size. And believe me, unfortunately, I'm not proud to say that it does happen, but it's a definite no-no. What is it? Well, you start with 20 and you analyze, and well, that's not quite what you expected. So you know what? Why don't we add an extra 10? So now the sample size is 30, and we analyze. It's still not quite what was expected, but it's kind of looking a little bit better. So why don't we add another 10? And now the sample size is 40, and then like that, you go on. No, no, that's not good. That's not good at all. Why? Because you're looking and we call it a fishing expedition. I'm going to keep doing this until I find something. But at the end of the day, when I find something, I don't know if it's real or because I was just fishing for answer. Now, if that's what you did and you don't have any problems with it, and okay, well, write it down in your paper. If you think there's nothing wrong with that, just write it down. And that's fine. I'm completely fine if you say, okay, I had to do this because of these very good reasons. Fine. Write it down in the manuscript that I had to do this because of these very good reasons. And you list the reasons. Baseline characteristics. In randomized studies, avoid statistical tests and reports of p-values for differences in baseline characteristics between treatment conditions. You don't need to test for differences in baseline characteristics when you have a randomized study, because the randomization is taking care of the balance. And if it's not, that's part of randomization. In non-randomized studies, you have to test for differences between groups to check for balance, because they were not randomized. So you say, you know, I looked at those, these are the sick people and these are the healthy people, but I want to see if, are we talking about the same age? Are we talking about same sex? Are we talking about same race? And then you want to test for that, because it was an observational study. And in surveys, compare the baseline characteristics from your sample. So, okay, so you've got responses, you collected some demographics, compare those demographics to the population of interest. If the population of interest is the US population, then you may want to compare to Census Bureau figures. So you say, well, look, in our, I'm making up numbers, in our sample, we had, you know, 70% white, and the Census Bureau says that in the US, there are 72% white. Again, I'm making up those numbers. Okay, so therefore our sample is not so much off from the US population. So that's the idea. And it's a very good idea. So I'm just going to give you something here. For example, is a clinical trial with 2 groups. And this is table 1, baseline characteristics, and they do p-values. And that's not really necessary. No need to test for baseline characteristics in a randomized trial. This is another study, again, randomized trial, 2 arms, 2 groups. They're having a table on baseline characteristics. They don't show p-values, so good for them. Well, but sort of, because if you go down the table, this is only the top part of the table. If you go down to the bottom of the table, they have a footnote that says no significant differences between groups. So in a way, they did test and they didn't find any significant differences. And there was no need for that footnote. I guess that's my point. Presentation of results. Do not highlight in the abstract summary only what turned out to be statistically significant. And again, it sounds, oh yeah, sure, what's new? Yeah, it makes sense. Well, you'll be surprised. It does happen that the primary research question is A, but nothing exciting was found. But B was a secondary and something was found. And so we talk about B in the abstract and we don't mention A? No, no. The primary was A, secondary was B. Remember that example I showed you? In the abstract, you say primary was A, didn't find, no difference. Secondary was B, found an interesting result. Report the value of the treatment effect and the corresponding confidence interval, similarly for all other important outcomes. So that's another practice that is really should try to follow, is write down what is the difference and give a confidence interval and include the value of the p-value. And show the full picture in a graph and with confidence interval. Include in the primary manuscript results of any sensitivity analysis. Sensitivity analysis is like when you do the primary analysis, but tweaking a few assumptions. So you say, oh, I assume normal distribution. What if I assume a gamma distribution? Or I assumed missing data. I didn't touch the missing data. What if I impute the missing data? So this is a slight variation of the primary analysis, just to see if the results are robust. Robust means that if you shake a few things, it's still this, you get the same story. And this is an example of a pretty good, of the points I made in the previous slides. So here is a trial. This is from my NIDA times. Woody was an investigator. And basically they showed, there are several good things about this graph. First, they show the full story over time. So the primary was only for weeks 4 through 12, but they show the rest. So they're basically showing the full, what happened. Not only that, they did the same analysis in 2 ways. They just looked at the observed data, with missing data was just missing. They didn't do anything to it. And the sensitivity analysis, they looked at the missing data was imputed, meaning was kind of filled with all kinds of statistical procedure, but that's another story. And then the question is, has the story changed? That's the real question. If the story has not changed, then we're pretty confident about the conclusion. But if the story has changed, then we need to look deeper. In this case, the story hasn't really changed. So that was a good thing. And what a nice touch is they added how many people were in at each time point. Reporting p-values. And I'm really going to stress this. Report the values of p-values, not inequalities. Don't use p less than 0.05, p less than 0.01. Just don't do it. Period. No exceptions. My personal advice, I don't know, I haven't heard it like written down in a paper or by some famous statistician, but I think it's a good practice to report p-values with 2 non-zero integers up to 4 decimal places. So for example, you would say it's 0.27. There is no need to go further down. 0.27, that's it, that's enough. But if you have a 0.058, go to 2 non-zero integers. So it's 0.58 instead of 0.06. Okay, if you have to go 4 decimal, you go 0.064. So, 2 non-zero integers, that's what you report, up to 4 decimal. And then when you get to 4, it really doesn't matter. And if it's less than 0.0001, you just say just less than 0.0001. But don't do this. Don't do this. Don't put a star and p-value less than 0.05. Don't do this. Okay, now here's the irony. I was a co-author on this 2009 paper. And even back then, now it's a lot clearer, but even back then, I didn't like it. And I talked to the primary author, the first author, and basically she said that this is the way the journal wants it, and this is the way we have to follow their convention. And so that's what we did. But look at this. In this case, they reported the value of the p-value. They reported the p-value. Okay? And here's the point. Look at these two p-values. One is 0.062 and one is 0.042. So if they had a star, the body pain would not get a star, and the mental health would get a star. And you wouldn't know that for mental health, it was just below 0.05, and for body pain, it was just above 0.05. You wouldn't know that. You would say, statistically significant for mental health and not significant for body pain. No difference for body pain. There is a difference for mental health. So if there's one thing I want you to keep from this whole talk, I mean, kind of, 0.062 is not that different from 0.042. Okay? They're not that different. It just happens that one is just below 0.05 and one is just above 0.05. But 0.05 is really kind of arbitrary. Well, semi-arbitrary, okay? There's nothing magic about this commonly used threshold of 0.05. In fact, 0.05, using 0.05 as a cutoff, has been banned by the American Statistical Association in 2019. And I'm going to tell you more about that. The American Statistical Association, which is a very respectable, the Association for American Statisticians, and it's actually a lot of international members, a lot, had a whole issue on this topic. And basically in that issue, they write in the editorial, they basically say it as a title of a section. Don't say statistically significant. Just don't say it. Don't use the 0.05 and don't say statistically significant. Okay, very important that we start this practice. Very important. I am convinced that that's the way we ought to do. How we ought to report results. So the funny part is, I said, okay, you know, I'm really on board with that. It makes perfect sense. There's nothing magic about 0.05, and the statistically significant, we need to get rid of it. Completely on board. But then I got papers that I was a co-author to review as a draft manuscript before we submit to the journal. And so I said, okay, I'm gonna do this. I'm gonna get rid of all the p less than 0.05. And everything that says statistically significant, I'm just gonna get rid of it. It was very hard. It was very hard. We got so much used to say, oh, statistically significant, p less than 0.05. And that was it. So how am I gonna replace that? And it was hard. It wasn't easy for me to find an alternative way of saying these things, because I was so much used to saying it that way. Until I reviewed a paper for publication, this time as a reviewer, not as a co-author, as a reviewer. And it was a revelation. They were doing it so simply that I thought, that's it. And ever since that review, it became really easy. And I'm going to show you, because people say, you know, can you tell me, give me an example of how you would say it? I'm going to show you. So this is the old way. HRSD, it's a Hamilton rating scale for depression. HRSD scores were significantly decreased at week 6 and 8 compared to week 2, p less than 0.01. Two problems, significantly and p less than 0.01. Okay, I want to change it. How do I change it? Very simple. HRSD scores decreased at week 6 and 8 compared to week 2. P is equal to 0.0001 and 0.0065 respectively. That's it. You got rid of the significantly and you got rid of that threshold. You are calling 0.001 as what you think is evidence for a decrease and 0.0065 as evidence for a decrease. So you're stating in your paper that scores have decreased at week 6 and 8 compared to week 2. That's your interpretation of these p-values. But here's the key point. If a reader thinks, oh no, 0.0065 is not good enough, fine. You can have your own opinion. But the authors are giving the reader the tools to make their own interpretation. They are writing their own interpretation. And here is what is their own interpretation based on what? These two p-values that you see here. And we are calling them, as authors, we are calling them a decrease. Reader doesn't agree, fine. Another example, there was a statistically significant decrease in total lymphocyte TL before and after treatment, P less than 0.05. Again, two problems, statistically significant P less than 0.05. Well, how much less? A lot less? A little bit less? I want to know. We change it. There was a decrease in total lymphocyte TL before and after treatment. The change was 1.2 kilobase. The 95% confidence interval was 0.2 to 2.2, and the p-value was 0.011. Full disclosure, here's the amount of change, the confidence interval, the p-value. We call it, authors, we call it a decrease. You don't think it's a decrease as a reader? Fine. But we call it a decrease. And here are all the numbers for the reader to make their own opinion. Okay. Then you want to translate the statistical results into simple language and or clinical terms, in clinical terms, and explain the impact, so what, of these results on clinical practice or scientific research. And let me show you an example. So this is about the association between percent days abstinent from alcohol, PDA, and percent days attending Alcoholics Anonymous. So what you see here, this is the regression coefficient, 0.38. This is at 3 months. So B is the regression coefficient. Standard error of the regression coefficient is 0.112. Okay? So they put a star. I would have put a p-value, but that's another, let's ignore that for now. So the question is, okay, what does this all mean? Well, the authors tell us in the text. First, they give the p-value here, so that's good. But they tell us in the text, going to an additional 2 AA meetings each week would be associated with an additional 3.3 days of abstinence per month. Beautiful. They explain this statistical jargon into simple English. If you go to an additional, this is what we found. It doesn't mean it's going to happen, but from our data, if one goes to an additional 2 AA meetings per week, it would be associated, it's connected to an additional 3.3 days of abstinence per month. Standardized effect size. I don't know if you heard about those. They are very popular particularly with the journal reviewers. Basically what they are is that it's basically the treatment effect divided by the standard deviation. And that's why it's called standardized. And the reason is now you can compare treatment effect size, standardized effect size from different studies based on different, it can be completely different studies, completely different outcome measures. It doesn't matter because you've scaled it. It's a unitless. It doesn't have a unit because it's an effect size divided by standard deviation. The units are the same. When you take the ratio, it's unitless. And then you say, okay, small effect size is around 0.1, medium effect size around 0.3, large effect size around 0.5. It doesn't matter what you're talking about. That's basically it. I'm not crazy about it because you basically translated this into abstract terms. Instead of talking about the unit you're talking about, so that the subject matter expert reads it and say, oh, okay, we've reduced the blood pressure by so much. Oh, okay, I see. Yes, it's a big deal. It's not a big deal, whatever. But the subject matter can name. But if you talk about standardized effect size, it's kind of, I don't know what it means. Multiple tests. When multiple tests are conducted for primary analysis, adjust for multiplicity and describe how it was done. So multiple tests is you do, and I'm going to show you an example. You do several tests. You try this, not you try. Your model, you're testing, for example, several differences. That's multiple tests. So you have to adjust for that. You have to be penalized for that, because by chance you may find something that looks like it really happened when in fact it's purely by chance. So what do? Do you adjust your p-value? There are two ways you can do this. You can adjust the p-value, so you report an adjusted p-value, or you say, okay, here are the original p-values, but just you reader, be aware that you have to penalize yourself because we've done multiple tests. So we authors, we would have considered anything around 0.01 to be, meaningful result. But because of this multiple test, we need to bring it down to penalize. And I tend to like the unadjusted p-value, to adjust the threshold, because you keep the p-value, the initial p-value that is not subject to the method of adjustment. If I use a method of adjustment and I adjust the p-value and the reader says, oh no, that's the wrong adjustment method, they cannot go back to the initial p-value. They're stuck. But if I show the initial p-value, the original p-value without touching it, and I say, you need to look at around 0.01 to have a meaningful result because of the multiple tests, then if the reader doesn't agree, fine, they can have their own threshold. When multiple tests are conducted for secondary and exploratory analysis, indicate the total number of tests that were conducted and a general rule of thumb for a new p-value threshold. Again, I'm talking about p-value threshold. I am not going to put stars and less than threshold. No, I'm not going to do that. I'm going to report p-values the way they are. But what I will do is when I write the text to say whether there was a decrease, there was an association, there was no association, etc., I'm going to use more or less a threshold. But I'm going to report it, the p-value. And if the reader doesn't agree, they can have their own opinion. So an example, like for example, this one, they says is to test the effectiveness of 2 interventions compared to usual care. So we have 2 interventions compared to usual care. So right there, so we have A versus usual care, B versus usual care, 2 tests right there. And in decreasing attitudinal barriers to cancer pain management, decreasing pain intensity, improving functional status, and quality of life. So the primary objective is comparing A versus usual care, B versus usual care in 4 outcomes. So that's really an example of multiple tests. So the title, A Little Humility, is always a good thing. What do I mean by that? It is rare. Let's face it. It is rare that results of any one study are definitive. Okay, so we need to be a little bit humble when we report results, and especially results from secondary and subgroup analysis are only preliminary and need to be confirmed with further research. So what I'm saying is avoid absolute language like we have shown that the medication is efficacious. it's too strong. It has to be repeated. It has to be confirmed. So you may want to say, it seems that, it appears that, our data show, our analysis shows, based on our data, something. I mean, you put your own style. I'm not telling you exactly how to write it, but just a little bit soften the statements. Supplementary tables. I think they're a great idea. Consider putting additional details in supplementary tables, particularly results from exploratory analysis that yielded small effects. So it's all out there. Increased transparency by disclosing in supplementary tables all or most of the other analyses performed. And of course, mention the supplementary tables in the paper so that the readers know that they are available if they're interested. So in summary, I'm going to list what I've talked about. It's basically, is the primary research question clear? This is a few key evaluation criteria. Ask yourself, in my manuscript, is the primary research question clear? Is it clear why it is an important question? Is it clearly described in the abstract? Is the primary endpoint clear? Is the analytic method clearly described? Are the main results clearly presented? Are confidence intervals reported? Are the implications of the results of the study discussed? So what? Are multiple tests performed? What did we do about it? Is a sensitivity analysis performed and reported? So this concludes the talk. I'm going to give you 2 slides for the references. So I'm going to put them there and just for a few seconds. So to give you time to pause. And that's the second slide. And with the references and a few seconds to pause. And that's the end of my talk. Thank you very much for watching. I hope it was helpful and it was worth your time. Bye.